looked for much research lately to support that theory. So one of the ways that we can treat gestational diabetes is we have some treatment goals that we want. So, before a meal, the blood sugar should be around 95 or less. 1 hour after a meal, 140. It's normal once you have a meal for your, blood sugars to go up. 2 hours after a meal, your blood sugar should start coming down. So 120 or less is the goal. And if we meet all those goals, then the risk of having a cesarean section for the mom is lowered by a lot. We can do basic lifestyle changes. We can teach the mom, diet, limiting your fat intake. Usually it's 30% of your daily intake or less. Lots of fruits and vegetables, that's kind of a given. Portion control, another thing that we have to really worry about with the mom, or anybody for that matter having diabetes. And exercise. For a type 1 or type 2 diabetic, exercise is really important. But for a mom, it becomes a little more complicated. If she's pregnant, she shouldn't be starting a new exercise program without consulting her doctor. Okay, a change in exercise can be very complicated and can cause a lot of problems for the baby and for the mom. So it's important to kind of keep the doctor in the loop as far as exercise is concerned. That's one of the teaching points that we make with our patients. So I kind of geared this, like I said, a lot towards my presentation, lots towards OBGYN. It's just, for type 1 diabetics, if mom's pregnant, we usually, the need for insulin increases a lot, and she needs insulin injections. Usually pregnant women, if they're type 1 already, they stay on the same insulin regimen as they were before, slight increase here and there, depending on blood sugars. Obviously, they need to be checking more often. It's important for them to do that so we can see kind of what their ranges are. And then for type 2, they can be on insulin and some sort of a pill form as well. And after delivery, like I said, mom is at risk for type 2. Doesn't mean she will develop it, but she's definitely at risk for it. And breastfeeding can actually lower blood sugars. Just something new that I learned. I did not know that, but it can definitely help with, maintaining that normal range. So, as I talked about, insulin for type 1 and type 2 does not come in pill form. It's through an injection or can be put in an insulin pump. As far as injecting insulin into the body, it's injected into the fat, subcutaneous tissue. It can be in the same general area of the body, but should never be in the same spot, an exact same spot, because it will cause extra fatty tissue to build up in that spot, which makes the insulin really ineffective. You're just hitting a hard spot every time. Your insulin is not going where it should be. So insulin enters your body at different speeds and works fastest when it's done in the abdomen. It's slower in your upper arm, and then it's slowest if you do it in your thighs and your buttocks, because you're more likely to hit the muscle there than the actual fat tissue. Injections are timed with meals, and usually you can give yourself insulin 30 minutes before you eat, because once you eat, your blood sugars are going to go up. That's a given for anybody. Most insulins take about 30 minutes to start working, so taking it before a meal allows the insulin to start working when the glucose from the food starts to enter your bloodstream. Injecting insulin for type 1 diabetics, usually they do two injections of insulin per day of 2 different types. They will do a short-acting and they will do a long-acting insulin. That usually progresses to 3 or 4 injections per day of a couple of different insulins. And the type of insulin is going to depend on your level, your blood sugar levels. And it was actually shown that injecting 3 or 4 times decreases the complications of diabetes, which is kidney disease and retinopathy and nerve damage neuropathy. For type 2, who are on insulin, they can get 1 injection per day without diabetes pills, or they can do a combination. And once those oral agents stop working, which they do, for some people it's just not sufficient, they do have to have 2 types of insulin as well. So we have fast-acting insulin, which works about 15 minutes after you inject it, and it's most effective in an hour of injection time. It works for 2 to 4 hours. It maintains your blood sugars at a steady level. And some of them, I don't know if you've come across, but Humalog, Novolog, Apidra, those are your fast-acting insulin. So if you need immediate, if you need to immediately lower it, that's what you would use, your Novolog or your Humalog. And the units that you inject are dependent on your weight. That's how we usually figure out how much a person should be given. So we have diabetic educators that work really closely with our patients and help us determine that. They really go into detail and look at everything. And it's also, we do a lot of carb counting as well. So based on how many carbs you eat per day, we do the units appropriately. We have regular short-acting insulin, which works about half an hour within injection. It's at its highest level of effectiveness 2 to 3 hours after you inject it. It lasts 3 to 6 hours. We have Humulin R and Novolin R, which is the same thing, just different company. That's the difference, really. We have intermediate acting, so those are effective for 12 to 18 hours after injection. That's called MPH, or Humulin or Novolin N. We have a couple of patients on those, but their blood sugars are not as erratic as other people's. Then we have the long-acting, which are your Lantus, and the newest one, Toujeo. I don't know if you've heard of that insulin that's being marketed right now. So basically they're trying to phase out Lantus. Their patent is expiring, I believe, and so they are trying to make a transition to Toujeo, which we have just a few patients on it thus far. Lantus, for example, will give you a fairly even coverage over a 24-hour period. Usually you inject it at nighttime insulin, that's what they call it, nighttime insulin, and it works for a good 24 hours. Toujeo, one of the many advantages of it is the fact that it provides its more steady coverage over a 24-hour period than Lantus is. They've done a lot of studies on it that shows that it's more effective, and it also causes a lot less hypoglycemic episodes, which is possible with any insulin, but Toujeo has definitely been one of the better ones as far as that's concerned. And also, Toujeo gives you about 1/3 volume. So when you're injecting it, it's 1/3 volume of Lantus. You still end up using the same units. If you were on Lantus, you want to switch to Toujeo, you switch to the same units of Toujeo to Lantus. So it's a 1-to-1 ratio. There's no change. You don't need to increase. So it's really important with patients to kind of educate on the fact that it's 1/3 volume, not 1/3 concentration.